Hej allihopa! Jag heter Felicia Kjaernet, jag är ST-läkare här på kirurgen i Karlstad och jag vill välkomna er alla till den här sessionen. Vi ska prata om det faktum att hur vi beter oss mot varandra i vår kliniska vardag har en direkt påverkan på hur väl vi presterar. Och då följaktligen har en direkt effekt på utfallet för patienten. Med oss har vi doktor Ganga Verma som är överläkare i obstetrik vid universitetssjukhuset i Southampton. Som i flera år har varit aktiv i organisationen Civility Saves Lives. Och hon kommer att föreläsa för oss om deras arbete. Sen efter det så kommer vi ha en kort diskussion med er och med panelen här. Som består av överläkare Mikael Bergenheim här på kirurgkliniken i Karlstad och specialistläkare Victoria Sem som är narkosläkare också här i Karlstad. Den här sessionen kommer att vara på engelska. So with that I have the great pleasure to introduce Dr. Ganga Verma who will start her lecture for us.
Hello, everyone. As Felicia said, I'm Ganga. I am a consultant in maternal and fetal medicine in Southampton. Thank you very much for inviting me to come here today and represent the Civility Saves Lives campaign. And thank you to all of you for coming in this early in the morning to listen to me speak. So I obviously am a clinician. But about 5 or 6 years ago, I became involved with the work of Civility Saves Lives, which is a campaign that was started in the middle of England, probably about 10 to 8 years ago now. And it was just started by 3 people that were sitting in a coffee room over a cup of coffee, talking about a uncomfortable incident that they had witnessed in a surgical theatre. In fact, it was a gynecology theatre that they had witnessed this incivil or rude scenario in. And they were discussing how that had then really negatively affected the mood in theatre, and the rest of the morning, everybody had felt the weight of what had just happened. It's a conversation that, unfortunately, many of us will have found ourselves involved in because we are so often exposed to these negative behaviours which happen for lots and lots of reasons. It's not because anybody is bad and wants to be incivil, but we're under a lot of pressure in our place of work. But these people, so Chris, Joe and Penny, decided that they weren't just going to talk about it, reflect and then move on, but they were actually going to try and make a difference. And that is when the Civility Saves Lives campaign was born. They gathered the evidence and they started to spread the message for just how important this is. And it's not just about remembering to be kind, but why are these behaviours happening? What impact does it really have? And do we need to do something about it? And as you'll see as my talk goes on, we do need to do something about it, and we'll have a look at why. Just before we started, we were talking about how both of our children this morning said to us, well, why are you going to talk to these people just about being nice? Isn't that just obvious? But I'm hoping that through this talk it will become obvious why we're needing to talk about it. So, what is incivility? Incivility is basically rudeness. It can be displayed in lots of different ways. So it could be disruptive behaviours like being angry or shouting at somebody, swearing at them, using bad language or verbal threats. It could be demeaning behaviours such as shaming, trying to teach people by humiliating them, which used to be very popular when I was a trainee. Intimidating behaviours, trying to be arrogant or hostile, sending rude emails. But one of the really important things that we sometimes forget is the non-verbal behaviours. So things like tutting or eye rolling, glaring, and just generally having a hostile or uninviting body language. The most important thing, and I think this is something that we often forget, is that rudeness or incivility is in the eye of the beholder. So if I have made somebody feel uncomfortable or upset because of the way that I have spoken to them, then I have to take responsibility for that. I have to be willing to acknowledge it and to rectify the situation, no matter what my intentions might have been in the way that I had behaved. So, why does it matter? There is a lot of evidence out there that suggests that high-functioning teams grow stronger together if they're working in an environment that promotes psychological safety. Psychological safety is a whole talk of itself, but it's just to kind of briefly talk about it, it's a concept that was developed by somebody called Amy Edmondson in the 1990s. She has got lots of YouTube videos and books and papers out there that you could look up if you are interested. But in summary, psychological safety is a condition wherein you feel like you're included as part of a team. You have a sense of feeling safe to learn and to contribute to the team, but you also feel safe to be able to challenge the status quo and to speak up. And all of this you are able to do without the fear of being judged or marginalized or being punished by others. So you're able to speak up not just because you're feeling brave that day, but actually because it's accepted and people accept being challenged and it's okay. And I think we would all agree that it's going to be nearly impossible to foster an environment that's truly psychologically safe if within that same environment, rudeness or incivility is allowed to be normal. So, well, what is the evidence? Why do we actually need to bother about any of this? Christine Porath is a professor from Georgetown University School of Business, so she's actually a businesswoman. But over the last 25 years or so, her and her team have generated a plethora of really strong evidence base through interviews and questionnaires, looking at people from all walks of life. So they've got doctors and nurses and lawyers that they have gathered data from. And they have basically come up with two conclusions. One is that incivility or rudeness is expensive, but very few organisations recognise or take action to do anything about it. So at the Civility Saves Lives campaign, I have some very talented colleagues who love to make an infographic, and they have really kindly summarised some of the evidence generated by Christine Porath and her team into a useful infographic. So what have they found? So they have found that when somebody experiences rudeness, 80% of the recipients will spend time or lose time worrying about that rudeness. 40% of them will reduce the quality of their work. Half of them will reduce their time at work. That could be through sickness, it could be through arriving late or leaving early, and just generally not giving that extra mile that so many of us have to give at our work. And a quarter of them will take it out on their service users, which in healthcare means us taking out our frustrations on our patients and their families. There's also a significant impact on the witnesses, so just those that have watched the rudeness. 20% of them will, or there will be a 20% decrease rather in their performance, and half the people will decrease their willingness to help each other. And again, we all know how much we rely on helping each other in our day-to-day work in healthcare. And finally, a significant impact on the service users as well. So 75% of people will lose enthusiasm for the organisation. So again, in the healthcare setting, that translates as our patients and their families losing their trust in us, which isn't something we can really afford to do. So a lot of people in this room are going to be scientifically minded, and there is, over the last 5 years or so, a growing body of evidence, research papers around workplace behaviours and specifically the impact within healthcare. And I'm just going to try and attempt to summarise some of those papers, and particularly the ones that I think are most relevant to our work. So the first two papers are going to demonstrate why different people might be differently affected by the rudeness that they witness or are subjected to, and it doesn't always click for everybody, and that's because not everybody is affected by it in the same way. So this first paper by Gillum and his team in 2020, they had about 112 participants, and they got everybody to fill in an emotional empathy questionnaire to try and work out a little bit more about the personality of these healthcare workers. They used quite a kind of crass way of dividing people up into a rude group and a polite group, depending on the scores from this emotional empathy questionnaire. They then had similar numbers in each of those groups, and got them to watch a video. So they either had to watch a video which was a bit rude and made people feel uncomfortable, and a separate video that just had some polite, banal content. They then got all of these participants to perform some cognitive performance tasks. And what did they find? So there was a decline in task performance after witnessing rudeness, which was differentially moderated by emotional empathy. So people that had a higher empathy had worse performance if they had watched the rude video. I think that's a really, really important piece of evidence. And there's two different ways in which we could interpret that. So one is that we could just say that actually people need to have less empathy. And maybe just be more resilient, and they need to be less affected by these negative behaviours. Or, and obviously I prefer this option, we need to reduce rudeness so that we can keep those people that have higher levels of emotional empathy in healthcare. I particularly like this paper because it really did kind of resonate with me, and it perhaps went some way in explaining to me why I was noticing these behaviours and was feeling affected by these behaviours more. This next paper assesses the effects of witnessed rudeness on some dental students and their psychomotor performance. So before exposing the participants to any rudeness, so when they first arrived, they were all asked to undertake an assessment to quantify their level of cognitive depletion. So what we mean by cognitive depletion, it's a theory that suggests that we all have a limited store of mental resources and the energy to devote to decision making. So the participants of this study then went on to witness either a rude or a neutral interaction in a lab. They then had to perform a mock dental procedure on a model. So the results showed that the students who had arrived cognitively depleted, so those who already had a reduced kind of mental capacity for making decisions because of everything else that was going on for them on that day, were more likely to make serious mistakes when they were performing the procedure, as opposed to those that had come in feeling fresh with kind of their battery set to full, as it were. I think that is really important, because we know more and more in healthcare that people are getting really burnt out, I was wondering if this was something that was specific to the UK and England, but the more I've been talking to people, I believe that's not true. And it is certainly a problem within Sweden as well. Everybody is overworked, and therefore we have to be mindful of that when people arrive at work, and we need to take that into consideration. So this next paper by Risking and their team in 2015, which is probably one of the earliest papers that I've come across that really looked at workplace behaviours. So this was a randomised control trial undertaken in Israel across 4 neonatal units. They had 72 participants, and each of them undertook an hour-long simulation session in small groups. They all underwent the same scenario, but some were randomised into a rude group and the others were randomised into a neutral group. The participants were told that they would be observed via a video link, and they had a brief address from an observer. And depending on which group they were in, the observer was either rude or just normal and neutral in their address. And they made the address right at the beginning and then a few minutes into the scenario. And then their performance of the teams was judged by the individuals who were blinded to the rudeness group. And they made judgments for diagnostic performance, for procedural performance, but also for information sharing and help seeking. So what they found, not surprisingly, is that the exposure to the rudeness negatively impacted all around. So it affected diagnosis, and it meant that people were less likely to be able to recognise the deteriorating neonate. They were less likely to recognise shock and cardiac tamponade. It also affected procedural skills with an impact, which the highest impact was seen in the ability to be able to resuscitate, to ventilate, and to be able to make sure that the tube was in the right place. In addition, rudeness also impacted information sharing and seeking help. And we know how important it is that we are able to speak freely, share our doubts, and share information. In particular in obstetrics, often when you come into the morning ward round, and I remember this as a registrar or a resident, you know that you would be questioned on all the cesarean sections that you'd done overnight. And if you felt psychologically safe in that environment, you would tell the overtaking team all of the details of what decisions you made and why, and how you may or may not have questioned yourself in your decision-making process. And you would make sure you'd given them the full story, which could then assist them in looking after those patients to their best ability. If, however, you knew that the people taking over were going to criticise you and question you, you would just be as quick as you can and just say, it was a bradycardia, she had a section, and move on, without perhaps telling them some really important details that might have got you to that decision in the first place. This was a prospective randomised observational study, and it looked at 76 well-performing anaesthetists. The participants were unaware of the purpose of the simulation, and they were assessed on vigilance, so how well they were observing what was going on, medical decision-making, communication, and teamwork. Again, they went in and did some simulated scenarios, which in this case was an intraoperative bleed. The surgeon and the nurse were actors, and the surgeon was asked to act as being impatient during the scenario. So they weren't shouting or being abusive at all, but just generally being impatient. And they tried to make the scenarios as realistic as possible. They also got the anaesthetist to self-report how they felt they had performed in that scenario. And here is what we found. So only 63% of the anaesthetists that were exposed to the rude surgeon performed at the expected level, compared to 91% of those that were exposed to the neutral or polite surgeon. But worryingly, and that's this box on the right-hand side, the self-reported assessment of how well the anaesthetists thought they did showed no difference. So they all thought that they had performed to their kind of expected standard, when the observers found otherwise. And I think this paper is particularly important because actually a lot of us that think we're not affected by rudeness and by these poor behaviours may not realise the hidden impact that it is having. So in this paper, a team of researchers from Vanderbilt University Medical Center, and this is the same group that have developed a pyramid of professionalism, which is something I'm going to talk about a little bit later. And they examined the outcome data from National Surgical Quality Improvement Programme for 2 medical centres. And they looked at 202 surgeons that had been operating on thousands of patients over the years. And they compared the outcomes of the surgeons who had been reported by their own co-workers for unprofessional behaviours with the surgeons that had had no such report. And they found that the patients of the surgeons who had 1 to 3 reports of unprofessional behaviours over the years had an 18% higher risk of estimated complications. And these complications included wound infections, pneumonia, blood clots, renal failure, stroke and heart attack. The patients whose surgeons had had 4 or more reports were 32% more likely to have these poor outcomes. Interestingly, and I'm not sure how relevant this is, but they did find that women surgeons were much less likely to have been reported for unprofessional conduct. So, what about education? I think a lot of us here have either been through the training programs or maybe going through them at the moment. All of the evidence that we've looked at so far is looking at how incivility and poor workplace behaviours affect our performance. But there isn't a lot of evidence out there about how it affects learning. Does it mean that people are more or less likely to learn? Is, in fact, education by humiliation the right way forward? I certainly hope not. But this review article by Laura and Chris, who are both members of the Civility Saves Lives campaign, was published in 2020, and it's a really interesting read. It acknowledges the growing body of evidence, but points out that a lot of work still needs to be done, specifically looking at incivility and learning, and it makes the case for more research. So, why does incivility exist? As far as I'm aware, not many people turn up to work or start their careers planning to be rude or uncivil clinicians. So, where does the evolution of the uncivil clinician come from? We all start our careers as a civil, polite clinician, wanting to do our best. Most of us have a caring nature, and that's why we've come into these professions in the first place. Unfortunately, and we've already touched upon this, we're all exposed to increasing levels of external pressures, both outside of work and at work. We may be tired, we may be hungry, we may be running late, we might have a lot on our plate. This is a clip I found from your video for this performance, and I was quite interested to see that there were lots of themes within that video that are very much relevant to this talk. But we also often work in a very permissive environment. So for years now, we have ignored poor behaviours. We have, and we see people higher up than us in the hierarchy chain that have been persistently rude, and they've been allowed to behave in that way. And in some ways, we've felt that we maybe need to model those behaviours, and we almost see it as a rite of passage. And that is how an incivil clinician comes into being. So there we have the evolution of incivility. What are we going to do about it? In these final slides, I'm going to talk about the resources that are out there that we can use as individuals, as well as on a hospital or departmental level, to try and combat incivility. Some of it is really simple. We can simply spread the word. We can talk about it in our coffee room. We can deliver talks. We can present any of these slides that I've presented today. We can do simulation training and set up workshops. This is a poster that was produced at a Somerset maternity department. They rolled out civility sessions as part of their annual mandatory training. So as obstetricians in the UK, we have to have a multidisciplinary skills session every year. We all have to go to it. And as well as discussing shoulder dystocias and PPHs, we're now encouraged more and more to talk about behaviours as well. So they brought in this mandatory civility lecture, just a 10-15 minute lecture to their MDT. They got everybody to do a pre-course questionnaire the very first time they brought it in, and then they sent out questionnaires again 3 months later. And they found that in the pre-course questionnaire, only 73% of people had been aware that there was a relationship between poor behaviours and patient safety. But they also found that more than 70% of people had either witnessed or experienced poor behaviours just in the last month. The results of the post-session questionnaire thankfully showed that everybody was now aware that there was a link, so that there is a link between poor behaviours and patient outcome and safety. But more interestingly, what they found is that only 50% of people had now witnessed or experienced poor behaviours in the last month. And I think that's really important, because what it's showing is that just starting to talk about it and acknowledge it can go some way to improving the workplace behaviours. Last year, my team put together a simulation-based teaching session for our obstetric trainees. We compared, we did scenarios of a major obstetric hemorrhage, and we had a really kind anaesthetist that kind of offered to come and help us and do a little bit of acting for us. And we split people up into 2 groups. In the first scenario, the anaesthetist was his normal, kind, polite self. In the other scenario, he was rude and less willing to help, shall we say. And what did we find? So we did get people to fill out questionnaires just to try and get an idea of how things went. And we also had a lot of discussion around it. It was a really, really useful session. So I was quite nervous when we first put it on. I'd never done simulation training for civility before. But the impact was really, really good to see. And some of it is hard to display in numbers, but just the conversations that it generated were really brilliant. But what we found was that there was a significant reduction in overall team performance in the uncivil environment. The biggest difference were in team morale and effective communication. We have written this paper up, and hopefully it is due for publication soon. So other things that we can do is that we can try and reduce the external stresses, and we can remove that permissive environment. The way that we can remove the permissive environment is by starting to call out poor behaviours. So we need to move away from allowing the poor behaviours to exist, to brush them under the carpet and say, well, that's just how Mr. Johnson is. This is a workplace behaviour toolkit from the Royal College of Obstetricians and Gynecologists, made in collaboration with Civility Saves Lives and the Royal College of Midwives. It was made by Ellen Knox and Sarah Quinn, who are colleagues of mine back at home. And they have obviously, the toolkit is freely available on the internet, and anybody can access the content on there. And there's some really, really useful tips and tricks. And although, of course, a lot of it is directed particularly at obs and gynae trainees in the UK, there are a lot of resources that are very much transferable. There's 8 modules on there, and you can just dip in and out rather than having to sit down for a whole day and go through the whole module. So if anybody is after more information, that is a good place to start. So we talked earlier about Gerald Hickson and his team from Vanderbilt that have created this promoting professionalism pyramid. They've done work around recognising the importance of promoting psychological safety, and they've designed this stepwise approach for calling out unprofessional behaviours. They suggest starting right at the bottom of the pyramid with really informal, what they call cup of coffee conversations. But then obviously for behaviours that are much more serious than that or are persistent, you then have to slowly make your way up the ladder to more formalised interventions. At the very bottom, they have the informal cup of tea intervention. And what they're saying is that when a negative behaviour is perceived, it needs to be pointed out to the individual or individuals there and then. We have to acknowledge that we are suggesting a huge culture change, because for years now, we haven't done that. We have allowed people to behave negatively. We have let them off. We've said, well, it's because they're tired, they're overworked, they're very important. So we need to take a U-turn on that. And we need to change a culture that is very much ingrained. It's going to take time and it's going to take some work, but it's definitely doable. So when we're calling it out, there does need to be a lot of thought put into how we do that. And we do see, unfortunately, it being done not in a great way sometimes. So it is really important that we put some thought into it. So I don't want everyone to go out and start shouting at people for being rude, because that kind of defeats the object. So who should do it? Where should we do it? And when should we do it? When we're planning these conversations, and it's usually best not to do it in the heat of the moment, but equally, you don't want to do it to leave it too long when the relevance has kind of passed. So the conversations can be done by various people. So they can be done by the person that's been affected by the rudeness themselves. Not everybody feels comfortable doing that. It can be done by a bystander, so somebody that has witnessed the rudeness. I know for me, I am happy to stand up for any of my colleagues if I have watched them being subjected to rudeness. But if somebody is directly rude to me, no matter how much experience I have in these conversations and how much I go around talking about it, I find it really hard to directly question somebody in the way that they have behaved towards me. So there isn't going to be a one-thing-fits-all here. There is also a concept of having a more formalized way of having this informal conversation. And that is the second messenger system. The second messenger system is a more structured approach, and it acknowledges that not everybody has the ability or feels comfortable having these conversations. But this is a way in which we can make sure that we don't just not do the conversation at all because we are worried about the impact it's going to have on us. The way it works is you look at all levels of your hierarchy. It acknowledges that peer-to-peer conversations are much, much easier than trying to talk to somebody that is much higher up the hierarchy than you, or having a conversation to people lower in the hierarchy than you as well, because those can be perceived in a very different way by the recipient. So it suggests nominating people in each level of the hierarchy and giving them some training in how to have these negative conversations, so that when these calling out conversations rather, so that when there is negative behaviour, it can be reported to the second messenger from the correct level of the hierarchy, who's received a bit of training, who can then sit down with a cup of coffee with the person that has behaved in a poor way and look into that. So, how do we frame that conversation? I think the structure is the same, regardless of whether you're doing it yourself, whether you're doing it as a bystander, or whether you're doing it as a second messenger. The really important bit is that you need to be calm and kind and compassionate. And you need to remain non-accusatory and non-judgmental. There are two purposes to the conversation. One is to show that you care about the person that you're talking to, and the other is to land the information. And you can divide that into three parts. So the first thing you're going to do is check in. How are you? Show them that you really are listening, and it's not just a passing by, how are you, but you actually want to know the answer, and you're going to really listen. You're then going to inquire and use an open-ended question to try and get their side of the story. So something like, so what happened this afternoon? And then you're going to let them speak and listen. And finally, you're going to deliver the message. They were upset, and I know that you would want to know. That is something that I find quite a useful way of doing it, because you're not making any judgments, you're not telling them what to do, you are just going to trust that they will know the right thing to do. The Workplace Behaviour Toolkit that I showed earlier, in Module 8 of that, there are some specific videos that we created that kind of talk you through how to have these conversations, and some of it's a bit embarrassing. However, it does deliver a really useful message if anybody wanted to look into that in any more detail. It does specifically focus on the second messenger system, but again, as we've said, the conversation can be very easily transferred to any way in which you might want to do it. And again, this is just a summary of how to have that conversation. So we need to stay calm, compassionate and kind. We need to have thought about what we're going to say. We need to be non-judgmental and non-accusatory. And then we need to do it in those three parts. So checking in, inquiring, and then delivering the message. So a few more resources that are available. So within that toolkit, we also designed some really useful posters. Again, they are freely available to download. If anybody feels that this might be a useful way of spreading the message in their department, you can print these posters out from the website and put them around your department. There are also, this is just one example, but lots of really useful infographics on the Civility Saves Lives website, which again, you're free to print off and put around your workplace to just show why all of this is so important. So those are some of the resources that you can look at if you wish to, and that brings me to the end of my talk. Thank you very much for listening.
Thank you very much, Ganga. So, are you surprised, audience? Oh. Can you relate? Yes? I think we talked a little bit here in our group as well, and I think all of us also can relate, actually. Mikael, you can relate to this?
Yeah, certainly. I'd like to start by thanking you, Dr. Verma. Excellent presentation, and taking things that we all have sensed and that we feel somehow, and showing us data and quantified a manner that describes and illustrates this, that we've all had feelings about. Certainly I recognize these situations. I think we all do. Everyone working in a surgical situation as a surgeon or other staff have been in situations where we feel that the ambience and the atmosphere in the room, in the surroundings, are influencing our performance. Two evident setups is the operating theater in the operating room, of course, it's very clear, But also I think about the trauma setting, which is also a very elaborate teamwork where we're all dependent on each other. And both of these situations, I think I've seen many, many times that the atmosphere and the degree of civility, if you like, in the room is extremely important. I think that we often tend to mix up the ability to make fast and efficient decisions with being rude. And we think that it's somehow okay to be rude if you make these strong and powerful decisions. That's kind of a tradition, I think, and it's very sad. It should actually be the other way around. If you have the ability to make strong decisions, which we all do from time to time, then you should also have the ability to be kind. And so I certainly recognize it, and I'm very impressed by your data and the talk. We can get back to later what we can do about it, because that's interesting too, I feel. So yeah, certainly.
And Victoria, what's your thoughts as an anesthesiologist on the other side of the, the patient?
Well, I totally agree, and thank you for a really nice lecture, because I definitely think that I see different kind of situations on a daily basis, and I've done that since I started as a medical student, and you just see it in a different way. But it was also very interesting to see the data, because the impact of it, because when you started, it was like, it's sort of like you're really familiar to it, but then the data about how much it affects, I found that really amazing and shocking a bit as well. And I think the main problem is, because I also agree that people don't come to work to be rude, because I have a lot of people that I see that are a bit rude sometimes, but then I can have a beer with them and they are really nice people. So there's something happening there about, like, from being that nice person, and something happens.
Are you suggesting alcohol in the workplace, Victoria?
No, no, but I think that communication is hard. I think that communication is hard, and it's hard because of many reasons. It's because of what I bring to work with in my backpack. Like what happened this morning, what am I going through in life, what kind of glasses do I wear today, like I'm an anesthesiologist and you're a surgeon, we see things through different ways. I'm a woman, I'm a doctor, and how much workload do I have, and all of these things affect about how I behave, and also how I react to someone else's behavior.
Yeah, you're absolutely right, and I think that's what kind of brought me to work as part of the Civility Saves Lives campaign, because I always had that feeling that it's not nice when people behave like that, or when I behave like that. And the reality is that we're all going to behave poorly from time to time. We do work in really high pressured environments, but what we can't do is to excuse it and say that, well, it was because I was tired and hungry, and move on. You have to then fix it. So you've had that rupture in that relationship, and you've got to then go on and repair that. And it's a bit like they talk about in parenting as well. But you can't just excuse the behaviour and say, well, that's okay, because it does have an impact. And actually the research studies show us that there is an impact, and there is more and more evidence coming out, which I think really helps show people, because at the end of the day we are all busy, but we're also scientifically minded, and in healthcare we know you can't change anything unless you can prove that it's evidence-based, and it might even save some money, so that always helps.
I have a question for you. If we're working a lot with communication now in the operating theater and so on, we have these check-ins before we start the surgery, we have the check-outs afterwards. In the wards, we're working a lot with communications and sitting down and talking about how was your day and what have we done and what could we have done better and so on. There's a lot of focus on that. Really, this is a perfect situation to address this kind of thing. Why do you think it's so difficult? We talk about many things, like why did you come late to the operating room. That's okay to ask, but why are these things so difficult to address?
I think it's partly just, it keeps coming back to that permissive environment where for so many years it has become traditional. It's become part of, some of it is seen as being respectful. If you're, especially if it's coming from the top of the hierarchy, that we shouldn't question them because they're, they're doing a very important job and they're doing their best. And it has just been allowed to be the way that things are, and people have accepted it. It's so common for colleagues of mine where somebody will be rude to them, and then actually somebody else will notice that. They'll go to the person that's feeling upset because of the rudeness they've experienced, and they'll say, I hope you're okay, but don't worry, they're always like that. But nobody will go and talk to the person that's been rude in the first place. It also depends on where they are. So the more that we're doing, obviously talking about Civility Saves Lives and Civility in my own unit, what we're now finding is that people are becoming aware, and they do want to talk about it, and they do want to question it. But they are much more likely to question it for somebody that has just done a one-off rude had a one-off rude encounter, and is maybe lower down in the hierarchy and is easier to talk to, is more approachable, is that kind of person that you would perhaps go for a beer with as well. But not everybody. So they're now self-selecting, and they're saying, fine, I'm going to call it out, but I'll only call it out with the people that's easy to do so, not the others. And I think it's going to take a lot of work before we're able to do it universally, but we've just got to keep trying.
I was also thinking about the permissive behaviors. Maybe a question for Mikael more, and also Ganga, that do we have a culture within the surgical fields that promotes the rude behavior and also promotes the reduction of social empathy? Like that you're supposed to be able to take it, otherwise you won't cut it?
Yeah, unfortunately, I think so, certainly. I've been working as a head of the department for many years, and I've been working with recruiting. And I hear this from almost everyone thinking about going into surgery, but this is one of the things that they are afraid of, that they are worried about. How is the atmosphere, the tradition of being rude or arrogant, and that it's almost like it's expected. And that's very, very sad. I'm not sure if it's specific for surgeons or if it's the same for anesthesiologists or gynecologists, but it's certainly present for us. I've heard it many, many times. And it's like an attitude, and it's almost as if it's expected. And if you are trying to address these kind of issues that you have been talking about now, it's like it's a sign of weakness, which is very unfortunate, I think.
Can you relate to that, Victoria, in your... No?
Of course, I think anesthesiologists are a bit nicer. No, but I think that I definitely think about it for you surgeons, but I also think like anesthesiologists as well, because we also spend time in the operation theater. So I also think that you need some kind of mental preparedness to handle it, because it is a special environment. And I think that a lot of people coming there react and think like, okay, this is not for me. And then we lose some people that we actually could use.
I've always also had the feeling that the impact of the surgeon, it's a bit narcissistic to say this, but the impact of the surgeon in charge in the operating room is perhaps the most important person in the room. Because you tend to come and go, you come there and you perform, and then you go to another room next door and you get the possibility to have a break and maybe ventilate a little bit and some frustration. But the surgeon in charge in the operating room is there the whole time and is sort of in charge for the progression of the thing that we are supposed to do, fixing the problem. So I think that it's at least very important that we as surgeons think about it all the time. I think we have the possibility to set the atmosphere if we really try, if we make an effort. I don't know if you agree, but...
Yeah, I totally agree. And if we are going into like, what can we do? I think that it's very interesting in the operating room, because if we could just like remove that we don't talk about each other when someone goes through the door, that is like one thing that it's not that difficult to change, you could think. But I mean, if the surgeon is like, no, we don't talk about the anesthesiologist when they have left the room, and then the anesthesiologist doesn't accept that anyone is talking about the surgeon when they have left the room, or like or the nurse or whoever, but we don't talk about the one who has left the room. Because I'm convinced that everyone in this room knows that this happens, and it sort of like sets the culture about how it is okay to behave towards other people.
Victoria, you said something before when we were talking about you work in the ambulance, in the helicopter.
Yes.
You said something about you had the possibility to, in the check-in, in the start of the day, you were talking about what kind of mood you were in, or could you explain a little bit about that? I thought that was very interesting.
Yeah, I work part-time in the pre-hospital setting in our helicopter here in Värmland. And then every day we have this check-in where we go like, do you have a cold or anything? And we also have mental status, so everyone has to say, what's your mental status of the day? And it's, of course, it's not a therapy consultation. It's more like, I have something, and if I want to, I can say that my dad is ill, or that I'm going through a divorce, or I have had a bad leaving at school today. But all of these things affect me, so I can say that, my mental status is not so good today, and then I can say that, so I want a point for that. So then I will get a point, like, because I think that I'm so affected today, so I will get 1 point, and then we have this score, so we can't have too many points, because then we're not allowed to work. But so that rarely happens. But everyone has to say, like, what's your mental status of today? So, and I try to use that at the hospital as well. So every night when I start working, I go to the operation ward, and I talk to my nurses, like, how are you doing? And they, of course, think that I'm very nice and a very nice person, that I want to know how they are, and of course I do as well. But I also want to know, like, how is their mental status of today? Like, how good will we work in the ER when that trauma comes in? And I think that is really nice to do. And I also sense that since my colleagues in the hospital know that we do that in the helicopter, when I'm in the operation ward, they can come up to me sometimes and say, just so you know, Victoria, I'm not really 100% today. I'm just 80. And then we talk like, okay, but then I will cover for you. Because we do this together, and we're a team. And if I know that they are only 80% today, then it's much easier to help them out and to lift them and to make them stronger. Yep. Mm.
And I also think it's important to remember that a lot of the external stressors that are on us, we can't actually do anything about them. We can't do anything about the trauma that comes in, or we can't do anything about the inflow in the emergency room, or if we have places on the ward or not. We can only affect how we react to that and how we react to other people. And I think that is also really important to remember, that a lot of the external stressors are not in our power to do anything about.
Yeah. No, absolutely right. And I think when I put out on that evolution of incivility, we can't do anything about the external stresses, but we can do something about the permissive environment. And I think that's the bit that we need to focus on.
So we just have a few minutes left. So I wonder if we have any questions We have a question from the audience. I don't know if you have a mic or if you just speak up high, maybe.
I can use a mic. Hanna Ribbing from Stockholm. Thank you for an excellent talk and interesting discussion. I was just wondering if you had noticed any cultural differences in this rudeness behavior. Sometimes maybe what's considered rude in Sweden is not the same in another country, and sometimes it could be difficult to judge what is rudeness in that sense. I don't know if you have a comment.
You're absolutely right. That's a really, really good question, because culturally people are different, and you can have people that come from a very, very different background where it is normal to behave in a certain way. In some cultures, please and thank you are just not part of the usual language as I might be used to. But that's where it comes out about having that kind, calm conversation over a cup of coffee. So you're not being accusatory. You're not saying that you did something rude. What you're saying is somebody felt that you were rude to them. And that's very subtle but very important difference, because you do have to take that into account. It's much easier when you know your team, when you know people that you work, and if you work in the same small team all the time. It's when you've got lots of different people coming in, it can be a lot harder, because you won't know the nuances about somebody's background and somebody's culture and how they might be different for various reasons. But if however they've behaved, even if it is completely their normal behaviour, is making other people around them feel uncomfortable, it is going to have an impact on their ability to perform, and therefore it still needs to be highlighted, and those people need to resolve that amongst themselves. And it might not be that person needs to change at all. It might just be a frank conversation to say, I'm really sorry, I didn't mean to be rude, this is who I am. And as they get more known, then it will be known that they're not being rude. But what we can't have is brushing that behaviour under the carpet, because then we are again starting to allow deliberate rude, behaviours that truly are rude.
Is there time for the second question?
Sure, go ahead.
Thank you very much for an excellent and very important talk, Dr. Verma. My name is Emmanuel Ezra, and I'm the head of department in our surgical unit. And I would like to ask you a question about the second messenger system, where you suggest that we avoid conversations going up and down the hierarchy gradient. So if my staff, usually a nurse or a nurse's aide, feel that the doctor, for example, doing the rounds have been rude, and there is no other doctor or a junior doctor present, they will come to me and ask me, so what do I do? My suggestion is always, please try to talk to the person yourself, but I will definitely support you and help you. But so this gradient, avoiding the gradient, please comment on that.
Again, excellent question. And I think what this really highlights is that we're all really different. So I've actually had a lot of people, and usually they are people at the top of the hierarchy, that will say, I don't see the problem, I can have this conversation with anybody. But that's partly because of personality, but partly because it is easy to have the conversation down the gradient. But there are people, and I absolutely include myself in this, I would find it, and I still find it, incredibly difficult to question somebody. So we have to be aware that we're all different, and not one thing isn't going to fit all. But the second messenger system takes a bit of work to establish, but what it's suggesting is that in each level, so if you, within your doctors, have defined levels, so we, for instance, have SHOs, and then we have registrars, and then we have consultants. So we nominate people in each of those groups. And the way some people do it, which I think is really great, is rather than getting people to volunteer for it, you get all of the SHOs to nominate a few SHOs within their team that they think would be good at having that conversation. And they think, actually, if this person came and talked to me over a cup of coffee and told me that I behaved in a way that made somebody feel uncomfortable, I think that conversation would be okay, and I feel like I'd be able to receive the message from them. And then obviously you need them to agree to it and provide them with a little bit of training. And the training itself only takes an hour or so. It's just going through the steps of how to have that conversation in a kind, compassionate manner. So what you would do if somebody came to you and said that, let's say, a registrar had been rude to their nurses, is you would find the designated registrar, who was the second messenger for the registrars, and ask them to have that conversation over a cup of coffee. And you would have people that you would know within all of those lists. And it's not easy. Of course it's not easy. People will spot the second messenger coming a mile off and think, oh no, I'm in trouble. But it has to be, it has to be done. And it is one way of doing it. So you're not then leaving it to the individuals that may actually just not have the personality that's required to be able to have those conversations for themselves.
Thank you.
Thank you. Unfortunately, it's time up. We are out of time, but it's really nice to see that it sparked a discussion. I guess that is the whole point of this talk, to spark thoughts and discussions, and how we can be able to work with this within our own units. I would like to thank the panel very much. I have some gift bags here. And so nice that you could be here with us today and talk and share your thoughts. And especially for you, Ganga, that you could be here today and spare your knowledge with us. Thank you. Thank you.